couple other people into a presentation by,
I can't hear.
a new vice president at Seton Healthcare, actually, for innovation in telehealth. Her title is Innovation in Telehealth. It was fascinating. I think the comment that she made, and this is more of a comment that gets to the question, but the that how far Texas is behind in telehealth, and Austin is even further behind than Dallas and Houston. And it was kind of a question: why is Austin so far behind when we think of Austin as being this big tech capital and everything?
Well, I probably have a prejudice for that, coming from the VA system, where we are connected. That research of mine at the VA, and that I've continued since being here at Texas State, is 10 years old. And the VA system says to their healthcare providers is 30% of your patient care has to be by telehealth. And so, but they do have connections already, video conferencing and that sort of thing, with the community-based clinics, the outreach clinics. So in Region 6 of Texas, that goes all the way to Louisiana, just around Houston itself is Bowman and Sugar Land and Galveston, and so those are outreach clinics. And they are doing that for economics as well as for the small number of providers they have, because if a veteran is 100% disabled, then they have to pay their travel. So economically it works, it's equal in care, and so telehealth is work, but telemedicine, where it's provider speaking to provider and provider providing care. But what we haven't done in nursing education, I fear, is we haven't taught RNs how to be that RN on the other end, who is applying the stethoscope, who is putting on the leads, who's doing those types of things to facilitate with a distant provider. I don't know why we're behind, except for we are in Texas.
Part of it is the medical community.
I was just going to say that.
Wanting that.
Well,
and interactivity of medical records as well.
Right.
No,
another part was back in 1995 through 2000, there was a tremendous push to put the infrastructure out there across all of Texas down to the border, and they put it out to all the clinics. So, you know, the video machines are there, interactive video, the whole 9 yards. But because the infrastructure was put in place, doesn't mean people use it. And so it sat and it languished, and it wasn't being used. It wasn't being taught how to be used. It wasn't encouraged to be used. And so it got put into closets. The technology continued to progress without repair. And so even though the infrastructure was there, it wasn't being used, especially in areas of high density like Austin, where people did not have as much of incentive because they didn't have to travel that far to go to the provider. So it was a dual-edged sword, but millions and millions of dollars were put in and then not implemented.
There's also a law, apparently there's a big lawsuit that the provider needs to see the patient face to face the first time, and then after that it can be telemedicine, but they have to see him face to face.
Well, that's not true in the federal government, because we're delivering care in Alaska to people that are so remote that you can. And
record system is connected.
correct, but we're all connected, even with the DoD.
Also, individual specialties have different rules.
Right. Yes.
Yes, sir.
And that's very true.
Now in the medical simulations, I know there's a lot of effort taken to simulate the activity, but you're also going the extra step to simulate the environment and create a hospital room environment. Are there any studies that look at the impact of simulating environment in addition to the activity to see if there's a benefit to that? I was wondering if anyone could speak on that.
I do know that there was a huge national study by the NCSBN, which is the coordinating board that does licensure for nurses, which found that nursing programs that have a 50% simulation component, so 50% clinical time, 50% simulation time, the students reported much greater confidence in their ability to.
How are they defining the simulation though? I mean, could you just simulate, could you take one of your simulation robots, throw it in a classroom without the hospital environment, and how would that level of education compare, the quality of education to actually.
For this
simulate
study
the
that
hospital?
Ann's talking about, your point is perfectly made, is that there is no standardization and nobody set any rules. And so at one school it was low-tech, and in another school it was high-tech, and some had a room that was environmentally looking like an ICU and others did not. So we need to do that work.
No, the NLM Laerdal studies that have occurred in simulation and education, in the first multi-site study, and I was part of that with the University of Maryland, one of the things that we were proving was that depending on the outcome objectives that you had, some of those same successes were occurring whether you had simply a bed down here in the front of a classroom and the actual simulation occurring, or you were in a full 360, we have a home care unit upstairs, it's a full apartment, or in an ICU. So what we were looking at in that one is, you know, are the students are learning, and are the observers also learning from that? What is the difference in that? And I think there needs to be more research in that, because what we found was that there was not a tremendous difference depending on the objectives that you were after. When you're going for that higher level that we are with the actual decision making and judgment, then the more we can put together, the better we're finding.
Yeah, and I think
There's also a definition. Remember, that National Council of State Boards of Nursing had some definitions, and every year I have to report how much simulation, how much computer skills, how many lab skill hours, how many clinical hours in the hospitals. And they define high fidelity simulation not by the level of mannequin or person or anything, it's by the debriefing that you have to, that it really is that whole, you know, you do the simulation no matter what it is, and it's that debriefing component that they always talk about is the most important part of any simulation, is the debriefing. So that makes a high fidelity simulation versus low fidelity, which
There's a lot of initiatives to standardize training of faculty and how to manage
Yes.
this, so that we're kind of raising the bar for everybody to kind of know how to do that appropriately.
Yeah, and another thing I was going to say, Clint, to address your question, the level of technology that you need is directly related to what you're trying to teach. If you're trying to teach students to differentiate between different heart sounds, all you need is a tape recorder. But if you're trying to teach students how to physically move in a space during a code simulation, like, you need a lot of equipment, because they're using a lot of equipment in this simulation, and they have to know how to use this equipment smoothly and carefully without tripping over each other or getting shocked or something like that.
And you know my background, the rest of the folks don't. So part of my job is to design and conduct disaster exercises for government and corporations. So if you look at federal disaster exercises, some of the really large conducted ones, they'll go as far as to blow up a bus and measure exactly where the shrapnel is and try to recreate that perfectly for the exercise in the shrapnel pattern and whatnot. Something like that, they don't, that particular type of exercise, they only do those usually once a year. And they're extremely expensive. So for me as a consultant, it comes down to a cost-benefit analysis.
Sure,
and so I like to understand, you know, what is the best bang for your buck when we're trying to recommend this for a client. In general, in training for exercise design, there's a concept of artificialities. And so the ideal exercise has as few artificialities as possible. So you practice like you play, of course. If you're going to respond and practice like you're in a command center, make sure that you're actually in your physical command center and practicing. So I know we try to limit our artificialities as much as possible, but again, there gets to be kind of a cost-benefit analysis associated to that. So I was interested in how some of the other fields have addressed this.
And it depends on what you're trying to teach. We do a lot of disaster simulation in the senior year, and we have a pretty low-tech solution to rapid triage, which is using little teddy bears. And the teddy bears have moulage on them, and they have a little card that says their stuff, and they have, what is it, 1 minute?
No, not even a minute. 30 seconds.
They have 30 seconds to examine, what, 15 teddy bears? And we have some rubber snakes in there too to look at bias and prejudice. And so, you know, that's a way that we teach them rapid triage in a mass casualty situation. It doesn't need to be high budget.
And that's why when we're looking at designing simulations, you always have to go to what are your objectives? What are you trying to get out? Because the level of reality really relates to what that objective is gonna be.
Correct.
You have to, it has to be real enough that the student's suspension of disbelief
Yeah.
can keep them engaged in what you're doing.
And
In
that
other
was-
words, if you can put an index card on an IV pump, and the tubing goes to an arm, and says, this pump is running at 165 milliliters an hour. Is that good, or do they actually need to deal with that pump beeping and fixing
Yes,
that? Because if you've got a 15-minute simulation, how much time do you want? What's the objective? Is it fixing the pump, or is it
Yeah.
dealing with the consequences of, hey, this math isn't right?
And it was really an eye-opener when we started looking at it to say, you know, if you've got 15 students and you're going through that, who's learning? You know, are the ones that are the gawkers, just sort of standing back? Are they learning the same as the ones who are in the key roles? And that's why we do assignment for the observers, so that they're participating, and the research is showing us that they're learning as well. So we've had to start shifting some of what we understand about that learning process to know that that full team can be moving forward in that learning journey to the outcomes, even if they're not all the ones that are standing there and adjusting the IV, putting the hands on the chest.
We can
And
squeeze in
for-
one more question.
So I was going to observe that one of the points in immersion that we didn't discuss, comes back to Chief Semihigh's work, is cognitive absorption. That for an activity to be immersive, it has to fill your brain, which means there has to be a match between difficulty and skill level.
So that was the Fiero slide that I touched over, the triumph and frustration.
But I wanted to sort of move on from that point. That was the preface to this, that a lot of the issues around, well, what do you put in, how much realism do you need, and so on, really is partly going to be a function of how cognitively engaging is the activity. If the activity is interesting enough, then your index card is sufficient. If your activity is boring, having that pump alive might raise the excitement level enough. And I wanted to actually draw an analogy to a completely different area, which is martial arts training. That's something else that I do in my spare time. I'm a black belt. And training students, I mean, we don't send people out to fight. I mean, there may be places, but it's not like 100 years ago where you'd go out and pick a fight to test your skills. So the training has to be much more cognitively interesting than this escape 500 times.
Or emotionally interesting.
Or emotionally. It has to in some way engage the person. And if engagement occurs, then the training is translatable. And if there is no engagement, if there isn't that cognitive, emotional, psychological engagement, then nothing comes out of it.
But there's also a balance between overstimulation too. So that becomes difficult. You don't want it to shut down because it's too cognitively stimulating.
Right, but again, that balance isn't very precise. So in other words, you don't have this, oh, I have to be careful, there's this ledge here. If you get anywhere in this space, you're good. And you can watch people and see if it's getting too intense, just calm it down.
But
It's
that's
not
one of the
like
re-
it's going to be, it's not digital, it doesn't suddenly flip
Right.
over.
But that's one reason simulation is so fantastic, because we can put them in that safe environment to take those risks. And as they move to that edge, then if they're successful and we can keep them going, then the next time they risk more and they try more.
Exactly, and that's
So
the
that's
same
where
thing.
simulation for us has really expanded.
As you get more skill,
Right.
you can up the level.
We've done research now back over in the clinical side without the simulation to show that the simulation has more value overall because you have less opportunities in the hospital setting to have those high impact events.
Right.
It just happens, when it happens, and so it's at that lower level.
Right. We've got to stop this so everybody has time to transition. Thank you to our presenters.